Okay, so welcome everybody to week 11. Only got a few weeks left of these lectures. Today's topic is all about healthcare access, and then we'll tie that into issues around aging in place. And so the theme of this whole week is really about healthcare accessibility and how we can make health services a little bit more accessible. So welcome everybody, to those of you just coming in. Okay. So I want to start off today's lecture by asking everybody, what makes healthcare accessible? What are some words or themes that come to mind when you think about healthcare accessibility? Cassandra says distance, Reed says geography. Any other things that pop up? Affordability, yeah, that's a big one, Zoe. Transportation. Yeah, these are all good. Mariana says equity, yeah, for sure. Inclusivity, yeah. Okay. So I think most of us have a general sense of what accessibility is, but generally it is more defined as centering around these three sort of broad themes or issues. So availability is a really important one, and we'll get into what all of these mean, reliability as well, and then the suitability of a healthcare system. So those are generally those three types of broad things that we would define as making a healthcare system or making healthcare services accessible. So let's take a look at what we mean by these three sort of general themes. So first off, availability. We're essentially asking, how easy is it to enter a healthcare system? And now many of you touched on the types of issues that would come up when we talk about availability. So a couple of you mentioned geography, and that's a really, really important one when we talk about availability of a healthcare service or a healthcare system more broadly. And so geographic proximity, essentially examining how close someone might be geographically in terms of distance, certainly as well any sort of barriers, geographic barriers. So whether that's something like transportation issues that I think someone else mentioned, road access, things like that would certainly come into play. And then of course, temporal availability, because as much as it's great if you have distance-wise easy access to something like a family doctor, if you have really long wait times, then that might also factor into how available a healthcare service might be to you. And so I just want to kind of bring up this figure here on the slide. So when we talk about these concepts of temporal or geographic issues regarding availability of healthcare services, this is kind of what we mean. So this is a figure showing the wait times, the median wait times that patients would wait from the time that they are referred from their family doctor to a specialist, and then the time that it takes from that specialist appointment to then get treated for whatever health issue that they're seeking treatment for. So as you can see, there's a pretty broad range of wait times. And this is in terms of weeks, but generally we say that on sort of the East Coast in the Maritime Atlantic provinces, patients usually end up waiting the longest for a lot of specialist treatments from specialized physicians. So it just goes to show that there is this geographic variability in terms of the availability of different health services or different aspects of a healthcare system. Now, someone also mentioned affordability, and that's of course, a really, really important aspect of whether or not a healthcare service or healthcare system is available to somebody. Luckily, here in Canada, generally affordability is a bit less of an issue in terms of doctor visits or hospital care. But of course, if we are talking about healthcare services more broadly, which might include something like dental care, which we talked about. So of course, something that wouldn't be covered under the traditional public healthcare system, such as dental or other services, then that might certainly be an affordability issue. And then there's this idea of acceptability. So acceptability and awareness around the actual use of a healthcare service or a healthcare system. the norms around whether or not someone goes to see their family doctor, for example. Are their parents, are their family members people who generally have a trust in the healthcare system? Those types of factors would also play into whether or not a healthcare service is available to somebody. Certainly whether they would want to or choose to go seek services. Now, availability is also great to discuss in terms of who actually has access to available healthcare services. So what does that mean? Well, we're saying that it basically depends on the healthcare system for one aspect, because again, bringing up this issue of affordability, considering if access to a healthcare service like a doctor's visit depends on something like your income, or the time that you're willing to spend waiting in an emergency room department, for example, then suddenly that would have impacts on whether or not a healthcare service would be available to somebody. And as we said, geography is a really important factor here. So it would also depend on your geographic location. Now, proximity to healthcare facilities is one really important aspect, but also the accessibility of staff members. So doctors, nurses, physicians, that's a really important part of whether or not a service will be available to you in your particular geographic region. Now, just to highlight some of these potential inequalities in access, let's take a look at just Ontario, where I think most of us are currently living. So this is a figure showing the percentage of adults who are able to see their primary care provider, and that's just your family doctor, on the same day or the next day. So within about 48 hours, let's say, if you were to try to seek care for some sort of illness or sickness that you want to get treated. So in Ontario, on average, a little bit under 50% of people are able to get an appointment with their family doctor within about 48 hours. Compare that to the North regions, so the Northeast as well as the Northwest regions of the province. We're talking about maybe closer to about a quarter of people. So that's a pretty drastic difference just by looking at geography and the difference in availability of certain services like a family doctor. So this definitely has repercussions on the availability of different services. Now, what does reliability mean? Reliability is just getting at this idea of whether services or access to those services is consistent. So can those services be regularly obtained? Now, you might think in your community, most of us, I think, live in more urban or suburban types of settings. Going out to seek care from, let's say, a walk-in clinic or a family doctor isn't generally an issue of reliability. We're usually able to get an appointment with some sort of doctor fairly consistently. It might not always be the same doctor, but usually you are able to get that kind of care. Now consider a community that doesn't have any roads, or permanent roads, I should say, to access it. So there's a huge swath of land in Northern Ontario where many people do live, particularly on First Nations communities. And these are usually fly-in communities. There's no permanent roads to access these communities. So they usually rely on winter roads in the wintertime or flying in during the warmer months. So this has some obvious repercussions on whether or not you can access something like a family doctor visit, because you do have to fly in a family doctor into these communities, and they tend to rotate out on different contracts that are for different periods of time. So this might be an issue, especially if someone is looking to establish any sort of rapport with one consistent doctor, knowing that they might only be in the community for a couple of months at a time, certainly would have repercussions on the availability or the type of treatment that you're able to get. Now let's talk about suitability. So suitability is just getting at this idea of whether the care that people need is what they're actually getting. So is there sort of that matchup between needs and receiving that type of treatment or care? In most places, again, places like Ontario or Southern Ontario, this might not be something that we think about, because generally, the type of treatment that we need is the type of treatment that we get. But in other places in Canada, this is not always the case. So let's take a look at Nunavut. In Nunavut, the residents often have to be flown out of the territory and flown into southern Canadian cities for more specialized care. Why is this? Well, there is a huge number of vacancies in terms of healthcare staff such as nurses, as well as other doctors, who are often based out of these sort of community healthcare clinics. Now, what happens when these jobs don't match up with viable candidates? Well, they go unfilled. And so people are not able to access the same types of treatments that they would in more urbanized or southern Canadian cities. So this is a huge problem in terms of especially the delivery of babies, for example. So any sort of complications with pregnancies, usually women have to be flown out of communities in Nunavut and flown towards Canadian cities that are able to provide more specialized type of care. So this has repercussions on the availability and the suitability of certain services in different places in Canada. Now, is healthcare utilization a choice? What do you guys think? To what degree do people have agency or choice in their use of healthcare services? So you're all saying yes. And who is it a choice for? Does everybody have a choice in terms of whether or not they use a healthcare service? What do you guys think? So Sumnima says whoever has access. So who might it be that actually has access? Lamisa says no, because of barriers such as availability and income. Any other perspectives? Mariana says some vaccinations may be required, so maybe not entirely. Okay, yeah. So some aspects of healthcare services or public health services, I suppose, might not be necessarily based on your own decision making. They might be to some extent mandatory. Any other ideas? Well, let's take a look at healthcare utilization. I think this is obvious to most of us in the terms of, well, okay, most people use healthcare systems or services when they need them, right? We're not all going to a family doctor every day to talk about, general ailments that we might have. Usually we go for a very specific purpose. But what this means is that it's the perceived level of illness and the access that determines the type of healthcare being sought. So for example, whether you're going to a family doctor or whether you're going to an emergency room. So who actually determines the illness level? And why might that be a problem? What do you guys think? Who is it that determines whether or not someone has an illness? So some of you are saying doctors, some of you are saying individual. Cassandra says yourself, or in the case of young kids, it would be the parents. Yeah, so there's an important kind of disconnect here, I think. Most of us have to make a sort of self-assessment, right, before we seek a type of care. We're really in charge of whether or not we're going to go receive that type of treatment or that type of service. So once we make a self-assessment of, okay, I'm feeling unwell, these are my symptoms, okay, maybe they're serious enough to warrant some kind of intervention, right? Either a family doctor visit or perhaps something more urgent. Now, there's an issue with this, of course, because not all illnesses have serious or acute symptoms. So on the one hand, someone might sort of brush off some symptoms and just say, oh, that's okay. I'll wait for my next family doctor appointment. There's no point in accessing care or utilizing a healthcare service now. of course, this is fine if the healthcare or if the health issue isn't that serious, but it could be potentially delaying care for an issue that might have actually benefited from intervention a lot sooner. On the other hand, someone may go to their emergency room because either they got a long wait time from their family doctor, so they didn't want to wait to go see their family doctor, or maybe they themselves thought that the issue was urgent enough that it should at least be looked at by an emergency room physician. This is another type of problem because, of course, healthcare in hospitals is a lot more expensive to deliver, to administer. So anytime someone visits an emergency room department, you are incurring a certain level of higher costs than you would if you were just going to go have an appointment with your family doctor. But of course, most people are not thinking about these decisions. They make a very quick assessment of whether or not I'm sick, how sick am I, what kind of care do I need. So it really does rest with the individual in terms of the type of healthcare utilization. Now, just to illustrate this, I want to highlight this figure here. So it's the percentage of adults who reported that the last time that they went to a hospital emergency room department, it was for a condition that they thought they could have been treated by a doctor, so a family doctor, for example, or a nurse, some kind of staff that they would usually maybe seek care from a medical clinic. So that percentage is particularly high in Canada as well as Ontario compared to some other countries. Why might this be? Why do you guys think the rate of people visiting an emergency room unnecessarily, perhaps, would be higher here? Any ideas? So Cassandra says it's more accessible. Sarah says because we're not concerned with any costs associated with visits. Yeah, so as Peyton also points out, in a universal healthcare model, no one worries about the costs here, right? So if you think you need that care right away, you're going to go to the hospital regardless of maybe how severe the health issue is. You're not the one incurring those costs, at least directly in that moment. Yeah, so these are potentially some of the drawbacks. There might just also be an accessibility issue in terms of family doctors. We know certainly in Canada, there is an issue, particularly in rural parts of Canada with family doctor access. There's significantly less family doctors available in a lot of parts of Canada. And so that might force someone to go visit their emergency room department instead of waiting for that appointment. Cassandra says, perhaps there are less resources to do a quick assessment. Yeah, that might also be an issue, right? If someone maybe isn't particularly well versed with what their symptoms could mean, maybe they would be a little bit more concerned and just want to go to a hospital to sort of get some peace of mind to make sure that nothing more serious was wrong. So another sort of important thing to point out would be that, of course, this can lead to people delaying their care if they are choosing to sort of forego treatments because maybe they don't think it's that serious, or again, it could lead to unnecessary hospital visits. Now, I also want to bring up that scheduling those annual appointments with a family doctor, for example, is a decision that people make. So in most places where accessibility isn't a huge issue, particularly in places like Southern Ontario, particularly in the GTA, where people have fairly reliable access to healthcare, deciding what type of care to receive is really, really an important personal decision that someone makes, right? If they have all these options, if they know that they can go visit a family doctor, if they can go visit a hospital, then that is a choice that they're making. So what type of behaviors do you think influences people to make that family doctor visit, that annual checkup, for example? We did talk about some of these a couple of weeks ago during the health psychology lecture. So assuming that there's no sort of urgent medical need, what do you guys think influences someone to schedule a regular family doctor visit? So Reed says gender, age. Nicole says risk perceptions. Yep. Any others? Social media. Let me, this says seeing family members, dealing with illnesses. Yeah. Yeah, so these are all important factors. So some of you touched on these types of social norms, right? If you see family members, for example, if there's other sort of social factors that would remind you to go see your family doctor, then that might instigate you to make that appointment. Of course, technology is a big one. And I think increasingly doctors' offices, as well as dental offices and other kind of healthcare services, are utilizing these types of electronic reminders to really try to push people to access preventative care regularly instead of sort of randomly when a big issue pops up. And this is another one we talked about. So trust or your satisfaction with the medical establishment, for example, your trust in doctors would certainly play a role in that. And then you guys talked about some other great factors. Now, I just want to kind of highlight with this figure here, this is a map showing the access to primary care physicians, so family doctors in Southern Ontario. Something you might notice is that even in a place like Southern Ontario, where we tend to think of the general density as being pretty medium high, certainly in the GTA, we have a lot of people. And so we have a lot of doctors usually available to access for patients. But of course, it's not equal. It's not uniformly distributed throughout Southern Ontario either. And so you do, of course, notice that a lot of the sort of clusterings of family doctors do occur in the bigger cities, as well as the sort of larger population centers compared to rural areas. So as much as we tend to generalize that, these types of issues of accessibility are worse in the north, we're fine in the south, it is kind of important to highlight that no, in Southern Ontario, we do also see these types of issues around accessibility play out. So just important to keep that in mind. Now, how does the utilization of healthcare services impact the access? Well, remember that healthcare systems are built and they're designed around projections of usage. So, for example, populations that we know of that access healthcare services usually more frequently than others, that might certainly play a role in how we would plan whether or not a hospital gets put in this particular location over another, or whether we would want to build a large medical facility that has different specialists or different types of care available. So what are these different factors that we're talking about? Of course, age is a big one. And so in Canada, for example, the population age 65 and up, so kind of the more senior of these citizens, they tend to account for almost 5 times more public expenditures on healthcare than the population under 65. So almost 5 times more costs associated with seniors. The consumption of their healthcare services does intensify as they age. And this is, of course, because the prevalence of chronic diseases, comorbidities, particularly among the older age group. Some of you also mentioned that females may have different levels of access. This has been studied that females do tend to utilize healthcare services a little bit more frequently, but also just the fact that their healthcare needs are very different, right? Females will incur generally more costs to a healthcare system because of things like fertility treatments, labor, delivery. These are very expensive types of procedures, but also females tend to live longer. And so they're accessing those healthcare services for a longer period of time over their life course. Now, income is another kind of factor that might affect usage, even in a place like Canada where we have a universal healthcare system. Because if you live somewhere like a low-income neighborhood, you tend to have a very different type of lifestyle, perhaps different exposures. And so your healthcare needs might be very different from someone who lives in a higher income neighborhood. Something like poor air quality might trigger something like asthma attacks. And so someone living in a low-income neighborhood might need to receive more frequent care for some of these types of health conditions. Certain occupations are also really important to consider because, as we know, many jobs have different levels of risk. They have different sort of dangers associated with them. And so some jobs do require more treatments. They require more treatments for those injuries, as well as long-term occupational diseases. And we'll touch on that a little bit more at the end of the term. So I just want to highlight in this particular figure here, when we're talking about the age of the populations, it's a really, really important factor that, of course, we have to consider anytime we talk about something like usage patterns in healthcare systems. And so just to kind of go and show that the majority, more than 50% of people who are admitted to unscheduled emergency room departments are in the older age category. So this is why we do tend to place a lot of our emphasis around age and specifically older age populations when we're planning things like healthcare services. Now, why does all this matter? Well, as I think we learned last week when we talked about healthcare systems and how they kind of work, we have a very limited amount of money in something like a universal healthcare system. And so that means we can't possibly build hospitals on every corner. So we have to be really, really strategic about where we put them, what kind of services we want to offer in them, how we want to space them out relative to other hospitals. We, of course, don't want to build two hospitals beside each other. That wouldn't really serve its purpose. But also balancing those diversity of different healthcare clinics and different specialized types of hospitals, for example, cancer hospitals, as well as others. These require even more planning because you do have to be able to attract specialized staff to operate in those types of facilities. So you can't really build those facilities anywhere. You have to really build them in places where you think you'll be able to attract a reliable and consistent workforce. What does this mean? Well, inevitably, a lot of these types of specialized healthcare systems or clinics, services, they do tend to cluster around major population centers, major cities. So this map is showing the access to specialized stroke clinics. And as you can see, the sort of black dots, which are the kind of highest level of sophistication in terms of the types of clinics, those tend to really be offered in the major population zones. So certainly Southern Ontario, as well as other kind of major cities across Canada. What does this mean? Well, unfortunately, if you are living somewhere a little bit more remote, maybe in a area with a smaller population, you're probably going to have to drive or try to make your way to one of those clinics in a much different way than if you lived in the same city as one of these clinics. So the access, again, is impacted by these types of factors. Now, we haven't spent much time talking about disability services. We've talked a lot about hospitals and family doctors, but I do want to touch on this because it is a really important part of healthcare services as a whole. Access to services for various disabilities does vary widely, and so it is definitely important to talk about accessibility here. These not only vary based on the type of disabilities, so the type of condition, but also the circumstances, as well as the government policies in place in terms of what kind of extra funding they might be offering families that are impacted by various disabilities. So one that many people are probably familiar with is autism, and autism services and supports things like therapies, psychologists, other professionals that tend to help with some of these symptoms or issues related to autism. Many of these services and supports are actually offered through schools. This means that not all schools that have the same level of services, sometimes extra supports are going to be required for families that need a particular type of specialized care. And so this just means that many families do end up needing private care, private type of therapies in order to access some of those services. So just to highlight what's going on here in Ontario, families are spending considerable amounts of their income on accessing these types of services that are not offered through public funding streams. So this was a report from the last couple of years, and it did highlight that some families were actually paying as much as $60,000 in a given year just to access very specialized type of care for their children that had autism. So what is the result of this? Well, there's an inequality here because, of course, the more income you have, the more access to these types of services that you will get. And in case anyone's wondering, the SLP here is speech language pathology, and the OT is occupational therapy. So those are two particular types of therapies that have been shown to be very helpful for some who have autism. Now, another issue related to access to these types of services is that once you are no longer in school, you really need to find your own way of accessing these types of services. And they are generally pretty limited for adults. So a lot of the times parents will have to place their young adult children on wait lists, kind of help them navigate a very complicated system. And really the amount of funding that families get can be quite variable, dependent on the child's needs as sort of dictated by their doctor and the healthcare system. So the access to these various services is definitely not at all equal and available to everybody equally. Worth noting is, of course, that most people do end up accessing a lot more privately received care, so care that they have paid for out of pocket compared to public. So worth highlighting that. Oops. There we go. So I want to ask you guys, how accessible is healthcare for older aged individuals? What do you guys think? Is accessibility to healthcare services an issue for seniors? So he says, I would say generally yes, because they can't drive themselves. So it is an issue. Reed says yes. Any other ideas or perspectives? With COVID-19, we've seen a lack of care towards seniors. Yep. Particularly unfortunate time to be witnessing some of the issues going on with seniors. Yeah, so let's take a look at some of these issues. Now, first, what makes seniors susceptible and vulnerable? Why is talking about accessibility so important? Well, as we know, seniors do have some characteristics that make them quite vulnerable or susceptible to issues around accessibility. So in particular, these would include disabilities related to physical mobility. So many seniors do have a pretty hard time getting around, and that certainly impacts whether or not they can go visit a family doctor. Many of them do suffer from some cognitive decline, and we'll talk about that in today's case study when we discuss dementia. And of course, there's this loss of steady income, right? They're not working anymore, so they're often reliant on a pretty limited pension. Certainly seniors who maybe haven't saved up for retirement extensively, then they might have issues maintaining something like car payments. They might decide to forego a car because it's simply too expensive. And so again, that might impact their accessibility to certain healthcare services. So it is a really important population to talk about when we talk about accessibility. Luckily, there are some ways that we can actually address some of these types of issues. So technologies related to improving mobility. We've all seen those types of electric scooters that some seniors do utilize in order to just make getting around a little bit easier. There are increasingly some transportation services that are made available, particularly in urban centers. So in Toronto, where I live, for example, there's a Wheel-Trans service that's part of the public transit system, the TTC here. And so people that have mobility issues, people in a wheelchair can actually access a type of bus that helps them get around, or in the city anyway. There's also this push towards building things like activity spaces or seniors hubs. And these are, if you think about it, kind of like a plaza, a one-stop shop where seniors can access all of their services in one really convenient location. And this just makes a huge difference in terms of providing care, more accessibility, if you can meet all of those needs in a single afternoon, let's say, and seniors can coordinate all their appointments very easily. So these are the types of things that healthcare systems are trying to move towards in order to bridge some of these gaps in accessibility. However, many barriers to access do remain. So one really important one, particularly in the GTA, where we have a huge multicultural society and kind of population of seniors, is that newcomer status and the awareness of different services and supports that are available can be drastically unequal across the board. So generally you kind of need help or someone to show you what's available, what you can qualify for in terms of publicly funded kind of senior services and things like that. In Toronto, just as an example, 15% of seniors are actually unable to speak English. And so they really have to rely on often their family members in order to translate documents, in order to help them book those appointments with their doctors, serve as interpreters anytime that they do need care. And so that just adds a level of complexity to provide accessible services. There's also the issue of language proficiency. And so again, being able to fully participate in things like seniors programs does require you to be at least communicating in a similar language. And so luckily in places like Toronto, there are some seniors programs that are available in particular languages that are not English instructed. So that could bridge some of those gaps, but in many other places in Canada, that is not the case. And so that can lead to some isolation for seniors who are not able to communicate in their language. And just to highlight what kind of languages we're talking about, here in Toronto, for example, there is a considerable Italian population that remains. So Italian is one of them, as well as Cantonese Chinese, Portuguese, Greek, Tagalog, Filipino, as well as others. So there's a huge kind of range of different languages that a place like Toronto does potentially have to try to provide interpreters, provide translation of documents. And so this can be a complicated thing to do. Now, other important barriers to access to highlight is something that we call friction of distance. So friction of distance is just the likelihood of using services like healthcare services diminishes as you increase the distance in order to obtain the service. So there's that kind of friction in order to go access a service if there's significant distance to obtaining it. This does play a role in healthcare accessibility, particularly for seniors, because many seniors, as we know, do have issues with mobility, maybe don't have steady access to something like a vehicle. And so they really rely on things that tend to be within their walking distance, particularly things like family doctor clinics in order to access that care. So just to sort of highlight that this issue really does happen everywhere. It's not just something that is in our imagination in rural places in Canada. This is a map of London, Ontario, so a medium-sized, fairly urban city here in Ontario. And this study was looking at the locations of family doctors in London, Ontario, and mapping that against the neighborhoods with high percentages of seniors living in them. So what they found is that while some places actually had a surplus of family doctors, so there was plenty of family doctors to go around for every senior citizen living there, other places did have a deficit, meaning that the seniors would not necessarily be able to access the same level of care. They would likely have longer waiting times in order to book an appointment in those particular neighborhoods. So this just goes to show you that even in a city, there are still issues with accessibility and ensuring equal participation, equal utilization of different healthcare services. Now, transportation is another really big thing here because somewhere like Toronto, less than half of seniors drive. So most of them really do rely on walking as well as public transportation in order to access things like a family doctor. Now, safety of the mode of transport is also really important to consider too, because walking is potentially very unsafe without things like traffic calming features, extended crossing times, things to sort of help people who maybe have some of those mobility issues get around a place like a city, particularly a city with a lot of traffic. And there's, of course, other built environmental features that would be really important to incorporate in order to improve that accessibility. The safety of transport as well is really important to note, even in rural places that do offer some sort of extra kind of bus services that are used to help seniors move around between different municipalities, for example. Not all of those have adequate features for wheelchairs. And so that, again, might impact how a senior citizen who maybe has those mobility issues is able to fully participate in something like that. So this kind of brings us to this question of, well, where is the best place for seniors to receive care, to receive things like social interactions? Consider that some seniors might live alone, but they maybe live in a place that they have a lot of access to seniors programs at their local community center. On the other hand, a pretty big proportion of seniors also live in assisted living residences or long-term care homes. but they don't get to necessarily choose their interactions or their care as freely. They've kind of offered what is given to them in that particular institution, but they're not necessarily making as many free decisions in the types of care that they're receiving or the types of interactions that they're getting. So this sort of brings us to the concept of emplacement. And emplacement just describes how living in a place with access to many healthcare services, community amenities, different friends and family is a really important part of seniors feeling security, feeling that sense of belonging in their place. And all of these things are really, really crucial for health and well-being. So this is why the issue of accessibility and how seniors are able to access different services, even healthcare, as well as different types of social services, this is why this stuff is so, so important. And I think no better example to kind of highlight this than what is going on currently. So one way to bridge a lot of these gaps to access that we've been talking about is to try to think of creative ways, particularly community outreach approaches that are able to reach seniors in some of those kind of harder to reach areas or harder to reach populations. So just thinking about the approaches to the COVID vaccine deployment here in Ontario anyway, I can't speak on behalf of other provinces. But here in Ontario, we were at first sort of focusing on delivering those vaccines specifically to care homes. However, once we started to deploy these vaccines to other seniors who are not living in these types of institutions, some issues around accessibility have popped up because most seniors have to travel now in order to access these vaccination clinics. And we know that not every senior has reliable access to someone like a caregiver or a family member who's able to drive them to a vaccine appointment. So what has happened is that there's actually been a significant sort of loss of patients that we were expecting to have vaccinated by now in sort of those 80 plus categories who have just not booked appointments, and public health officials are a little bit confused on how to proceed. Some of these have dealt with issues around pre-registering for these vaccine appointments online. And of course, that adds a level of complexity for some seniors who maybe aren't as technologically literate as we maybe expected them to be or hoped that they might be. And so we've had to do things like add telephone lines, bring some of these mobile clinics to areas or to neighborhoods where particularly vulnerable seniors might live. And so there are numerous issues that are associated with these types of different approaches. Now, I want to make sure we have enough time to discuss a quick little case study about dementia and care. We briefly, I think, discussed just the sheer prevalence or kind of common link here of dementia in places like Canada. You know, 1 in 4 is about the odds of someone in Ontario being diagnosed with dementia later in life. And so it is something that I think many of us are a little bit familiar with, but maybe now we can try to challenge some of our preconceived notions about what dementia is. I certainly learned a lot in preparing these slides on dementia. So to begin, what is dementia and what are the symptoms? Well, dementia is not actually a disease. Dementia is a collection of symptoms that can be linked to various diseases. So dementia is specifically the symptoms related to cognitive functioning loss, as well as memory loss, issues with language, problem solving, difficulty controlling emotions as well. So that's another big one. What are the causes of dementia? Well, this is a little bit fuzzy. Based on what we know so far, we do know, of course, that older age individuals do tend to be diagnosed with dementia more frequently. Some neurodegenerative diseases as well have been linked to it. Most famously, I think Alzheimer's is one that many people are familiar with. There's also some evidence that would suggest that vascular diseases, things like stroke, might play a role in terms of the increased risk of something like dementia, traumatic brain injuries as well, and then a host of other potential factors that are still kind of being studied and are poorly understood. So how is it diagnosed? Usually, a family doctor needs to refer a patient to a specialist in order to administer some kind of testing. So things like neurological, psychological, as well as cognitive tests. They might also require something like a CT or an MRI of the brain in order to really nail down that this is a diagnosis of dementia. Unfortunately, many doctors still mistakenly believe that memory loss or cognitive decline is just a normal part of aging. There's this sort of idea that, yeah, as you age, you'll just forget a lot of things, and that's totally normal. But it's not really normal. In fact, certain levels of cognitive decline are quite abnormal. And so they are symptoms like this that doctors really should pay attention to, but many are just not quite well versed enough in something like dementia and the symptoms around it. Many doctors are still kind of learning. We've only really been studying dementia in a lot of detail kind of in the last decade. And so a lot of evidence is still emerging about what it is that dementia looks like and how it might progress differently in different patients. So what are the barriers to receiving that diagnosis? Well, of course, it requires a patient or a caregiver to raise these concerns. So they have to be very vocal about their symptoms when they do visit that family doctor. Again, family doctors don't always recognize it, and so they won't necessarily refer a patient for a diagnosis from a specialist. And because of the fact that it requires a specialist, so someone like a specialist with a geriatrician, for example, a behavioral neurologist, neuropsychiatrist, these types of specialists, you know, not receiving that referral to that specialist can make the difference between receiving a diagnosis and not. And so there's so many levels of kind of barriers that could be introduced in order to receiving that diagnosis correctly. Now, what about the barriers to care? So once you've received that diagnosis, what happens? Well, you can kind of choose to some extent what type of care you want or should get based on your particular needs and the symptoms that you might have associated with dementia. Not all in-home care, so we're talking specifically about people like personal support workers as well as nurse visits. So not all of those types of services are actually government funded. You have to qualify for certain programs. You need to seek criteria, especially based on income. And so if you don't qualify for these types of programs, or if you're put on a wait list, you might have to seek private providers or private types of care. This might mean that you potentially have to face some pretty long wait times for therapies that have been shown to slow down the progression of things like dementia, as well as treatments from specialists. And this is really, really important because the longer that you delay the treatments for something like dementia or therapies, the more advanced that the disease does tend to get. And so you really do need to ensure that you introduce that intervention pretty early on in order to have better outcomes. There's also long wait times for long-term care homes. And so what's the problem here is that many older and sick patients have to wait many months in hospitals before a bed frees up in a long-term care homes. And so they're essentially being treated in a hospital for something that could be treated at home, but maybe they don't have a caregiver that is able to give them that kind of 24/7 care. And there's no space for them in a long-term care home that would be able to provide that type of care. And so many of these seniors are just sort of stuck in a hospital waiting to be moved somewhere else. This means potentially a lot of hospital beds that are being taken up by patients like this who are probably going to be better treated in other circumstances, in other settings, but we just don't have the capacity to treat them elsewhere. So just to kind of illustrate this, this figure is the median number of days that seniors who had dementia waited to be moved to that long-term care home once they were admitted to a hospital. So on average, we're talking something like 90 days, about 3 months before a senior who has dementia, who has maybe a particularly severe case of it with some symptoms that are not able to be treated at home with something like a personal support worker or a caregiver. So waiting up to 3 months before they are able to get a spot in a long-term care home. And some, of course, do wait longer. This is sort of the average, the median time. We have a question. This just happened to my granddad who has dementia last month. It took 3 months for him to be moved from the hospital. I'm so sorry to hear that. Yeah, that is really unfortunate. Unfortunately, it's an issue that does take place here pretty regularly. Now, this has been particularly exacerbated during COVID. And so I know we have a couple of minutes left that I want to talk about this stuff. So access to in-home support can, of course, be risky, particularly during times of COVID, because those personal support workers do tend to have numerous potential clients or patients that they have to visit. And so this certainly introduced the potential for outbreaks pretty early on. So we've tried to limit the number of patients, for example, that a personal support worker can treat. There's also been a pause on a lot of adult in-person programs, which have been really therapeutic to many people who are diagnosed with dementia. And so they're no longer able to access them. Sometimes they're able to access some kind of supplemental services online, but it hasn't really been studied whether or not these have been as effective or have really met the needs of these types of patients. So what's the result? Well, unfortunately, a lot of caregivers, so family members as well as friends or paid staff, are needed to sort of pick up the slack and really care for people with dementia, because there are just so many holes in the system, particularly during something like COVID, which has really exacerbated many of these problems. So I just want to end on this last slide today. So what has happened to the access to long-term care homes during COVID? Well, a surge of COVID cases in many of these long-term care homes had significant impacts on the access to something like dementia care specifically. So as we know, there were lots of staff shortages due to outbreaks. There were generally fewer visits to and from physicians coming into the long-term care homes because it was just sort of deemed a little bit too risky if there was an ongoing outbreak at the care home, for example. There's also this isolation of patients and the pause on many therapeutic activities that had to take place. And so many sort of anecdotal stories have come out about what type of impacts that has had on the care of patients that really, really benefited from kind of in-person social interactions and, behavioral therapeutic services like that. And of course, it's been tough because end-of-life decisions often had to be made without face-to-face discussions, and particularly with something like dementia, where already the level of cognitive decline may impact something like recognizing a family member. That's really tough to not be able to say goodbye to a family member, who has these types of symptoms, but also being forced to do it sort of virtually instead of in person. So worth noting. Now, I just want to highlight quickly that the proportion of staff employed in homes were personal support workers, by and large, the vast majority working in long-term care homes. And these workers are also the lowest paid, the lowest wage. So perhaps not a coincidence here. I think hopefully something that we'll maybe learn out of this whole pandemic is just the sheer pressure and sort of need for many of these types of low wage workers, often who were not able to access things like paid sick leave, and hopefully we'll really try to help them as we take a look back at some of the things that could have been done a little bit better in terms of long-term care, particularly during COVID, but for many, many years to come in the future when we start looking at these things. So let's end the lecture there. Tomorrow, we'll actually continue talking about a lot of this stuff related to accessibility. We'll talk about services, particularly in rural and remote areas. We'll take a look at that a little bit more specifically. So thanks, everybody. Enjoy the rest of your day.